again, this question, about the staging, we've already covered that all the criteria based on traditional imaging, but we all are using PSMA PETs as an adjunct for the borderline patient, or maybe if they're symptomatic, but clinical imaging and the symptoms are the main guide. And do you guys really go into the details about which tracer is being used? Like, I don't, as long as we can get a PSMA PET scan, but is any one of you following whether it's gallium or whatnot at all your sites?
Actually,
I mean, you guys have the PET scan now at your site.
Yeah, we do, but I don't look at that.
Okay.
I don't think it gives us the option when we order it.
We just order PET, a prostate PET, and it comes up. And
Yeah. Are you?
Well, I think I don't really look at it unless you're comparing apples to oranges. Let's say if someone got an F18, someone got a gallium-68, and there may be some discordance, and I would discuss it with one of our esteemed colleagues in nuclear medicine.
Yeah.
But you're right, I don't get to choose, because it's a lot of this, I believe, is supply chain and storage considerations.
Yeah. We've actually now incorporated a nuclear medicine dedicated person to look at our PET scans, because we were getting all these different opinions. So for our tumor boards, just so you know, we have that. So our next question is, for patients with low volume disease that you've identified on a PSMA PET scan, how do you manage their care if the traditional imaging is not showing any changes? Moshe, like you said, you're following response on the traditional imaging. Let's say patient is doing well, PSA is responding, traditional imaging doesn't show progression, you'll continue the same treatment, right? You won't just do a PET scan to see what's going on.
Right. I mean, I believe what I see. So again, if the patient is feeling well and the PSA is not rising or rising slowly and there's no change on imaging, I'm not going to chase something down.
Yeah.
I think really the difficulty with PSMA PET imaging is in the treatment-naive metastatic hormone-sensitive patient. Because in that setting, what you have is you have all the studies were done with traditional imaging.
Yeah.
So there might be a patient where if you got a routine CT scan and bone scan, they may have low volume disease by charted criteria, but if you go ahead and now you get a PSMA PET scan, suddenly it's high volume. So do you treat that patient as low volume because that's what they used in the trials, or do you treat them as high volume because at the end of the day they're high volume because that's what you see?
Yeah.
I treat them, again, by what I see. If it's high volume, that's what I treat. You try to give patients the benefit of the doubt up front. I think the first treatment in the metastatic hormone-sensitive space is probably the most important decision to make for patients. We're trying to keep them hormone-sensitive for as long as possible. So if I see a high-volume disease on PSMA PET imaging, I'm not thinking to myself, well, maybe it's low volume on traditional imaging.
Right.
I'm giving them the benefit of the doubt, and I'm treating them as a more aggressive disease.
And do you find that the PSMA PET scans can sometimes be a nuisance, like in our tumor board, we see every little thing that's lighting up is being called progression. What's your most commonly seen false positive that, it's not real, but they're still calling it progression?
Well, I mean, you have to be careful with that too, because I had a situation where I have a second primary. So I think that, pictures tells a story, but, I went ahead and did a biopsy, and then, I have a PET that was not SUV as high as it was before, but certainly was concerning, and I did a biopsy, and there had to be another adenocarcinoma of primary lung tumor. So then I have a metastatic prostate cancer, along with a lung cancer primary in an elderly patient. I'm glad I did the biopsy. Potentially I could do SBRT, was not other side of metastasis. I did an EVAS. But I think that the false positive could be the inflammations. We have many patients with, especially histoplasmosis, sarcoid, situations like that. But also, especially in elderly population, high-risk patients, we have to be attentive to a secondary primary. Like in this situation, it was not through progression. It was a secondary malignancy.
Second, yeah. Just yesterday, I reviewed a patient with the lipomas all lighting up on the PET scan. So,
I think the site that we most commonly see where the nuclear medicine docs will say that might be a false positive is the bone.
Is the bone, especially the rib,
Right, and actually I had another situation like that, which I contacted the radiologist, what I go through, PET, or I go through the bone,
Yeah.
So it's the patient is symptomatic, so I'm trying to go with. But I think the clinical, we never should leave the clinical aspect of it too.
But the question is biopsy, the use of biopsy on progression. I know the histology can change and go to high-grade neuroendocrine So when do you trigger that biopsy option? Like sometime if I see like the volume is like growing very fast, that's where I do it. But I want to hear what you think.
Is the PSA going up in that
If
case?
the
Patient
PSA
is
is-
symptomatic. Yeah, I think anytime you're seeing, I mean, in my practice, if somebody's PSA is really low and the scan shows something new, I always biopsy that.
Discordance.
That's when you
Yeah.
really worry about the neuroendocrine progression. If the PSA is going up and the scans show new sites, then it's most likely, not neuroendocrine.
The same thing.
So yeah, so I've not been biopsying everybody, but
No, absolutely.
Absolutely not.
There's a lot of discussion about getting repeat NGS testing
Right.
with progression in patients with prostate cancer. We're almost never able to biopsy upon progression for NGS testing. It's usually done by blood
yeah.
Absolutely.
because it's just the patients need that next line of therapy. They don't want to wait. It's often bone only. So for NGS purposes, I usually don't biopsy.
Yeah.
But again, if there's a discordance with the low PSA and high tumor volume, it would make sense.
So I think we already discussed this. Let's say, you get a referral from radiation oncology for somebody with intermediate or high risk localized prostate cancer, but you obtained a PET scan and it shows N1 disease. You'll manage them. You have to give them the benefit of the doubt. Like we can't go by the historic classification. And I think it's high time that, the RECIST should include PSMA PET for our future prostate cancer trials. And again, we already discussed that if the traditional imaging is negative, but PSMA PET is definitely positive, we're going to base our treatment decisions on
Yes.
that. So let me ask you this. So what are you doing for the oligometastatic CSPC patients, and how do you define oligometastatic disease? Brian, are you doing a multidisciplinary approach with radonc, and how are you approaching these patients with, let's say, just 2 bone mets?
Yeah,
newly
so
diagnosed?
we are now seeing this. So I will definitely get my radiation colleagues involved to see if they're going to be a candidate for, at least prostate radiation alone, based on the, I think it was the Stampede trial. But I've had isolated single bone mets that have been treated with SBRT, and I've had patients with PSA go down to 0, and these people theoretically cured, I don't know, but we will continue to follow them. I think SBRT definitely has a role in all of
And you continue the hormonal therapy and the intensified ARI, or do you give them a break if, let's say, they've responded really well to the primary?
So I have one guy who has been doing terrible with ADT. He's got, I think, almost 2 years of therapy now with no evidence of disease. PSA is at 0, and I stopped his therapy because of his quality of life issues.
So, we had a trial called Medicure trial at the clinic out of MSKCC, where this was the patient population. We intensified, ADT plus ARI, then radiating the primary and SBRT, and then stopping everything at 9 months. And then they later made it 6 months. And many of those patients I'm following who have very low PSA despite T recovery. So I think it's something we need to follow with de-escalation of therapy.
I think
But on trial.
On trial, yeah, but I think, you may have a real, in the real time, a patient who is questioning if the PSA is undetectable, there's nothing on scans, do you need to continue therapy? I think that's it's a very interesting question.
I'm sorry, go ahead.
Dr. Haines makes a great point, though, with these de novo low-volume metastatic disease, that primary prostatic radiation, there should be that referral to radiation oncology. There is a survival benefit, as you alluded to in Stampede.
Yeah, and I think, the historic assumption that ADT should be lifelong, that was in the era when we didn't have any life-prolonging ARIs or abiraterone or any other therapies or lutetium. So I think there's a lot of interest in how we treat oligometastatic.
That's a common question I get, people second, third line, like, really, do I need to continue this? What benefit am I getting?
Moshe, what are you doing in your practice? Are you saying, no, this is lifelong for you, or you're trying to de-escalate if they've had let's say, great response, PET scan is not lighting up anymore, PSA is close to undetectable?
So I think it depends. If all the metastatic sites were treated with definitive intent, I still try to keep patients on therapy for a minimum of 2 years.
Correct.
So there's two different patients here. There's the patient that presents with de novo synchronous metastatic disease that's oligometastatic. And there I try, again, to give the patient the benefit of the doubt that you'll get prostate-directed radiation, you'll get SBRT to 1 to 3 sites, and doublet therapy for 2 years, and we will reevaluate at 2 years discontinuing therapy, assuming the first P of the patient is okay, the PSA is okay, and the pictures, the images look fine. Then there's that second patient who had treatment already to their prostate a couple of years ago, has a rising PSA, and now has oligometastatic disease. So that's a different picture. And those patients, the data is all over the place.
Yeah.
Right? We pretty much all agree that they should have metastatic directed therapy. The question is, in that patient with recurrent disease that's oligometastatic, what do you do with systemic therapy? And the data range from 6 months of ADT alone to 2 years of doublet therapy.
Yeah.
So I try to take everything into consideration. How long did it take for the recurrence to occur from their primary treatment? What's the PSA doubling time? What was their initial pathology? And then using all of that to decide on what ADT, whether to give a combination and for how long.
And depending on patients' comorbidities and how they're tolerating the ADT.
Yeah,
Do you have any preference?
No, I feel that initially the patient will take whatever you tell them. You know,
Yeah.
like triple therapy, double therapy,
2 years,
yeah,
5
2
years.
years, 3 to 5 years, and then the side effects kick in. And one of the, besides the, I think that the fatigue is one of the, especially elderly population, one of the biggest. And I mean, they start telling me, I'm glad that my PSA is low, but I don't know if I want to continue anything else like that. So I like that idea of the 3 Ps. I'm going to use that in my clinic. But it's, definitely the patient also, will define, especially after 2 years, I think either will come from us, will come from the patient, especially if they're feeling well.
Yeah.
I believe there's an ongoing radiation cooperative group trial where they're doing metastasis-directed therapy and they're randomizing to short-term ADT or placebo.
Yeah.
So it'll be interesting when that reads out.
And also there's another trial where it's called delay castration trial, where they're not doing any ADT at all, just doing SBRT to the metastatic sites and lutetium. So that's another trial. So there's a lot of interest in this space. Just like the Germans have been doing. I had 2 of my patients who didn't want any ADT despite recommendations, and they went to Germany and just got lutetium, So I think we need more trials in this space.